So good afternoon, everyone. Without any further delays, I'll be starting with the next session, which is on dioptric distress, errors in biometry, and solutions for it. So this session of ours has been going on for almost now 8 years, 9 years, since 2015. And this instruction course has been there for, as I told you, for the last 8 years, and it's been running successfully. And most of my co-instructors are there here with me. So without further delays, this instruction course is all about getting the best results for your patient as a cataract surgeon, because cataract surgery nowadays is a refractive surgery, and it's just giving the best results as the patient wants them for your every patient, whether it's a normal eye or it's a suboptimal eye, whatever it is, the patient wants the best for him. And you as a surgeon, when you're dealing with such patients, you have to give them the best which their eye can have. So let's start with the first talk of the session, which is on biometry basics, and I myself am speaking on it. So I'll be starting with the first talk of the day, of the session. At the same time, I'll ask my co-instructors, Dr. Vanity and Dr. Jasleen, to come over and sit on the dais for chairing the session. You come after me. Yeah. Then
this place.
Jasleen will come. Yeah, Jasleen is third. Fourth will be Shashwat. Fifth will be Shani, and last will be Rishi. Can you just change this? Wait. Yeah, 8 minutes, 8 minutes, 7 minutes. I think we can keep 8 minutes. Yeah, it's 8 minutes. Because we'll have one less talk. We can take up questions for his talk later on. ये लाइट क्या भैया ऐसे ही आएगा क्या? तो ब्लाइंडिंग कर रही है मुझे इसको. हाँ, इसको थोड़ा कम करो तो सीधा आंखों पर. हाँ, बंद कर दो फिर. इससे तो मुझे ये दिखेगा नहीं, थोड़ी देर में मैं ब्लाइंड हो जाऊंगी. दिखना तो चाहिए स्लाइड्स पे. बहुत ज़्यादा स्ट्रॉन्ग है. नहीं लग रहा क्या? हाँ? नहीं हो गया? नहीं हो रहा क्या हो गया इसको? आपके पास है एप्पल का? वो लगा लो, अपना लगा के देखो. नहीं आया क्या? क्यों? ले लिया? तो आप लोग का बोर्ड आ गया.
You have lunch? Yeah, I was also. I didn't go out because it's too humid. But I went and had a quick bite because we don't get.
हो गया?
Who was there? Family is there? Just
उसको बंद कर दो ना, नीचे वाले को बंद कर दो.
I've been to Kochi before.
ऐसे बंद कर दो ना. इस पे क्यों पिसलेगा? ठीक है, हाथ से
Anybody
बंद
else
कर दो.
coming from shore? Last.
नहीं हुआ ना? कहाँ है भैया? हाँ? एस्केप करूँ?
Okay. The younger lot are all there. NMS is there? No. Same as the रेटिना से कम लोग आए ना. वो दोनों.
So let's start with the first talk. That's on biometry basics. So I'll be just covering very quickly about the basics, things which you should be doing so as to get the best measurements, so as to avoid any errors. What is the biometry? Biometry, as we all know, is the process of measuring various physical parameters and using these parameters of the eye to determine the ideal intraocular lens power, which would be ideal for that patient of yours. So first and foremost important thing is gathering a good data. So what is the essential data in this is your axial length and the corneal power, which we measure by keratometry measurements, and the additional inputs which can be taken are your AC depth, your lens thickness, refraction, the predicted force of refraction, the white to white, and the age, which are usually considered in holiday 2 formulas. As well as, remember, these 4 parameters, the keratometry, AC depth, lens thickness, and refraction, have a very, very important role in predicting your ELP, or the effective lens position, which is the actual position of the intraocular lens, which is you are trying to predict before the surgery for that particular patient. So who should be doing the biometry? Remember, you are the surgeon, you are responsible for your patients. So ideally, you should be doing it for all your patients. But if you do not have the time, if you have a busy practice, ensure that your assistant, whoever is doing it for you, is well trained to pick up any anomalies and inform them to you, or he's able to take care of all the parameters or the machine related fallacies or the calculation related fallacies which may arise. When should you do it? It is a matter of great timing as well. You should have ample time to calculate the IL power, time to counsel the patient if there are odd powers, or what type of refractive error does he want? Does he want an emetropia? Because emetropia may not be the target always. And it will give you time to arrange for specific powers which are out of the range, which are not the normal. Remember, as I said, emetropia is not your goal always. You have to take into consideration patient's needs and what are his requirements. So the first thing is keratometry, or the estimation of the true corneal power. And a good K reading is required for directly using it in the IL formulas, for indirectly estimating the ELP, and as well as for controlling your astigmatism, which is happening during the surgery, as well as the preoperative astigmatism, which the patient may have, to counter that as well. Most of the instruments or the keratometers, what you are doing is measuring the anterior radius of curvature, and then presuming these refractive index, the overall refractive index of cornea, it is actually calculating the power of the cornea, or the true power of the cornea. But nowadays, we have a lot of armamentariums of machines which have come up, which are able to give us an assumption or an estimation of the posterior corneal radius also, curvature also. So we have these armamentarium. I'm not going to go into details of any of these machines. But remember, I'm just going to talk about the tips which you should take when you're doing your measurements. Please always, whatever instrument you're using, calibrate it regularly at regular intervals. Ensure that whatever measurements you're doing, you do it in a dark room with a good tear film and untouched cornea. You should not have done any procedure. Don't be in a hurry to do first an applanation and then you start with your thing. Or if you've done an applanation, please don't do your keratometry on the same day. Please reschedule the visit of the patient. Ensure that there is other eye is occluded, because that ensures the axial readings or an axial centration of the center most part of the cornea being measured. Take average or multiple readings. If there is an evident scarring which is involving most of the cornea, then you can use the other eye readings. But with the newer modalities of measurements, they will be able to give you some approximate values for the measurements. Remember, most of the corneas are curved regularly and similar between the two eyes of the individual. 99% of your readings are between 40 to 48 diopters. So if you have variations beyond this, recheck. Extreme values, more than 40, less than 40, or more than 48, recheck. If asymmetry between the two eyes or greater than 1, recheck. If there is astigmatism within the eye or greater than 1.5, recheck. Do it on different days by different people involved and on different machines, where all these machines, as I told you, will come into play. For the next input parameter, we have the axial length, for which we have the tools, the ultrasonic biometers and the optical biometers. How do the ultrasonic biometers work? Obviously, it is basically based on the ultrasound waves being traversed from very different ocular structures, and the distance traversed is thereby calculated from the echoes which are reflected. Again, the tips for this is, please always calibrate your instruments, set the velocity settings correctly, the gain settings properly, appropriately. A very, very gentle touch if you're using a contact biometer, a contact probe. Ensure that there's no indentation happening, because that is a major source of error. Look for good spikes. What are good spikes? I'll just show you in the next the diagrammatic representation of that. Ensure that there's axial alignment, which is very, very important when you're doing measurements with any biometer. And in this, for ultrasonic, by asking to look into the fixation lights. Again, take average or multiple readings with a standard deviation between each reading less than 0.06 millimeters. Repeat if the difference between the two eyes is more than 0.3. Preferably always record before or take measurements before dilating the pupils. Again, this ensures your axial measurements. Avoid using any ointments, or if the patient is on ointments, please ensure that the readings are taken after some few hours of installation of the ointment. So as I was talking about the spikes, ensure that each spike is tall and steeply rising from your baseline. The retinal spike is almost of the same reflectivity as your lens and the posterior and the scleral spikes, and there should not be any small spikes immediately in front of the retinal spike. There should be a tall scleral spike immediately after your retinal spike and with the attenuating orbital fat spikes. If these attenuating orbital fat spikes are not there, it indicates that your probe is growing through the optic nerve and not through the fovea. Remember that. So these orbital attenuating fat spikes are also very important in your scan. So what are the pros of using an ultrasound machine? Obviously, it is easy to perform and cost effective and works for all types of cataracts, even the densest or a total cataract, which may not be case with some of the optical biometers. The disadvantages obviously are there. It is misalignment issues are more common as compared to optical biometers. Risk of abrasion may be there with the contact ultrasound, contact probe, and the risk of infection is always there because it's a contact procedure. And again, in the contact ultrasound, there is a risk of corneal compression leading to a falsely low exit length. So this can be improvised by just a mere investment of a Pringles shell, which will help you in going into the immersion mode of ultrasound. This shell is basically looks like this, where the water bath is created within shell and the probe is immersed into this water bath, where the water is filled up to a level of almost 70 to 80%. And while doing immersion biometry, remember that the patient is comfortable. So you can either keep the patient supine or even in the reclining position. Align the mark on the shell properly with the probe inside, which is submerged in the water bath there. Fill the chamber adequately without any air bubbles. That is important. Ensure that there's no leakage. So overflow is not required, should not be there. Ask again for the patient to look in the fixation light. That's important to ensure that the alignment is being done in the XL direction, and make sure that the machine is in immersion mode. This is the most important thing to remember. Many a times this happens that if your operator is running it, or if somebody else is measuring, your optometrist is doing it for you, he has not changed the mode from the contact mode to the immersion mode. And that will give you erroneous readings and leading to faulty IL power calculations. And you landing up with a refractive surprise the next day itself. So the thing is, obviously, as compared to a contact ultrasound, this makes your measurements more reliable, more accurate. There's no corneal compression. So obviously, the exit length is not being falsely recorded. And again, the other advantages of the ultrasound are there, that is going to work for all types of cataract. And the only disadvantage for this, I would say, is there's a risk of patient getting wet. Now, next is your optical biometers, basically, which are using infrared diode lasers, which are based on various principles. We have PCI based, we have OLCR based, we have swept source OCT based. Various optical machines, biometer machines are available to us. The basic thing in these machines is the resolution is far much better because of wavelength which we are using is the infrared rays. And so if you look at the accuracy, obviously with the A scan, it is somewhere between 0.12 to 0.24, which is markedly improved with using an optical biometer. The tips for this is ensuring a moist ocular surface, ensuring alignment, a slight mid-races, especially in the cases of PSCs, in these cases may be helpful, and choosing the correct mode. Obviously, the advantages of this machine is very high reliability, observer independent, fast, precise, and same machine can give you various measurements which are required for your as input parameters. There's no physical contact, non-contact procedure, no anesthesia, no corneal compression, and you're measuring exactly along the visual axis. The only disadvantage is it's expensive and it may not work in the cases of total cataracts. In significant axial opacities, now the swept source OCTs do work in most of the cases. So what next after gathering? You have to start employing some formulas. We have an armamentarium of formulas based on versions, based on ray tracing principles, based on artificial intelligence. And there are statements which are coming up, use this for short eyes, use this for long eyes. But remember not to use this. You can use any IL formulas. I'll be talking on the next talk about optimization, what is more important, but what is most important, not to use SRK2. Please, this is an obsolete formula, don't use this. And just an example of this, look at this. There's a 22 exit length, there's a 21.98, and with the same formula, the difference which we are getting, with a difference of 0.01 millimeter, you're getting a difference of 1 diopter, which is huge, tremendous difference for the patient. So there are 5 different steps at which this error happens with SRK2, so please don't use this formula. In the end, I would just say, please, whenever you're doing biometries, do it for both eyes. Always use the correct mode. Remember, most individuals have similar exit lengths in each eye. So if you have variations, recheck your readings. Similarly, most corneas are regularly curved. So if you have variations beyond this range, please recheck. Look for asymmetry, and if the asymmetry is occurring on different days, on rechecking also, then think of the causes of asymmetries, which could be amblyopia, staphyloma, any covert corneal scarrings. Repeat the measurements in these cases, as I've already talked about. Also, if there is a difference more than 0.3 or between the fellow eyes in terms of excellence, or the difference of mean corneal power more than 0.9 between the two eyes, if the difference of the emetropic implant power of the two eyes is more than 1 diopters. Again, repeat on different days, different machines. Use multiple formulas so as to cut down on your so as to go closer to accuracy. And remember, if you have to do any adjustments because of any complication during the surgeries, please remember to change the bag versus sulcus. And don't remember, it's not 0.5 diopter for every eye. It will depend upon the exit length or the reading. So please remember to remember this. Practically, you can remember it by rule of 9. And especially if you're changing your IOL model, again, you have to recalculate. You cannot use the same a different company IOL and use the same calculations and same power for this different company IOL. And different A constants are also remembered there for if you have done measurements from an optical or an ultrasonic. If your IOL model, the package doesn't provide you that, ask the company person to give you that if you're using the same type of IOL for all your patients. Audit your results scientifically and record your mean errors and use them to optimize your results. And there are suboptimal eyes, which my other co-instructors will be talking about. So these are those conditions which will be discussed in the next subsequent talks. I'll next shift to my other talk, which is on optimization, which I'll be talking in continuity of this.
Any questions from the audience, please? A very concise, a quick question can we allow? No? Then Dr. Nitya, please shift to next talk.
Yeah. So optimization, what is optimization and is it the need of the hour? Yeah, I would say it is the need of the hour. It is a way to go if you have to become a cataract refractive surgeon. We have, as I have already said in my previous slide, they have an armamentarium of IOL formulas which are working quite well. It's not that they're not working well, but remember each IOL formula has its limitations, and that is why we have statements. SRKT is good for long eyes, Hoffer Q is good for short eyes. So let's take an example. So these are the input parameters which I have put in. The A constant which I have put as given by the company person. But look, the range of variation which I get with using different formulas. None of the formulas is even closer to each other. Every formula is 0.5, 1 diopter away from each other. So what to do? What should I do? What if I choose incorrectly? So either I'll have a patient like this, or sometimes even a patient who comes fighting like this. This may be a familiar scenario. I have done an excellent surgery. My cornea is pristinely clear. I have a very, very quiet eye, but patient is really, really unhappy and is on to you. So this is because you have ended with a large refractive surprise. So now what do? I just pray, please, Genie, aa jao. I need something. So this is what is optimization. Optimization is just Genie for me. He's going to bring magic into my practice. Because I need to hit the target right dead at this point. So optimization, as I said, is the way to go. And why does we need to optimize? There are so many sources of error, which could be human errors, but there are certain errors which are calibration errors. Maybe my machine is showing calibration, but it has not been well calibrated over days. So I'm not checking for calibration of the machine every day. The company people say, okay, you can check the calibration maybe after 3 months. You need to recalibrate and call us over. But maybe it is not like that. So there are certain inherent errors which are going amiss from my mind. There are certain inherent errors due to assumption of speed of sound, refractive index of the cornea, etc. Other things. So this is because the anterior and posterior segments of the eye are not proportional. So don't presume that the speed of light is, as I am presumed when I am doing ultrasonic measurements, speed of sound is going to be the same throughout as, okay, this much is the anterior segment and this is the posterior segment. This is not the same case for every eye. Then we have the IOL design features. Okay, every IOL has its own design of haptics, overall size, shape, rigidity of the haptic junction, but we cannot predict that. How it is going to interact when it is sitting in the capsular bag, what is the ELP, we are trying to predict, but still we cannot be 100% sure of that. So obviously that is also another sort of inherent error which we cannot totally exclude. And then we have our surgical own technique, which is going to induce some errors which are inherent, which are a constant feature there, which could be the excess size, the centration, the way we have placed the IOL, how much viscoelastic we were able to remove from all the places in the eye. If we are using sutures, what is the suturing technique? What is the wound healing for that particular patient? How much postoperative steroids would we use? How did the patient's eye behave regarding to wound healing? So all these things obviously are also going to create source errors. So if you look for any IOL formula, the three things which we need to feed into that formula is your exit length, the keratometry values, and the lens constant. So it is this lens constant which actually determines all these variables, all these errors are taken into account by that lens constant. So what is this lens constant? These are lens constants which are provided by the manufacturers to us, which are based on certain empirical values, based on their theoretical considerations, based on certain limited clinical data which they have, and experience with similar designs. And they will come back again, their R&E section will come up and will give us a IOL constants based on the sticker on the package of the IOL. But remember, these constant, although the word is a constant, but they are still not constant, they are variables. So they are going to vary for each formula, each design of the IOL, each patient. They can, and so what is the starting point for us in optimization is this constant which has been given by the manufacturer to us. And they have been given different names, SRK in the different formulas. SRK-based formulas name it as A constant, but the Holidays formulas label it as surgeon's factors. Hopper Q names it as a pseudophakic ACD, and the Haigis as A0, A1, A2, depending on which version of Haigis you are using. So what are the ingredients for optimizing your A constants? The same things, the preoperative keratometry, the preoperative axial length. Now, the next thing which is important now, it is IOL power and the model which you are going to use, and the post-operative refractive error which you have from your previous experience of your previous cases. Also, the other things when you have to optimize, please remember, single surgeon has to optimize. You cannot take data of other people and optimize your constants. So single surgeon, single lens model, single biometry machine, one style of surgery. You cannot have a temporal incision and superior incision being combined and to take your results, to calculate your own constants. In the back placement of IOL, you cannot use in the sulcus and in the back placement, both the cases together, no. And a standardized refraction of where the postoperative refraction is being done for every patient, that also has to be standardized. So let's take a basic example using the simplest SRK formula. We just rearrange this equation to get this A constant. This is how we calculate it, okay? Now we calculate this for a series of cases, average these values, and use this A constant now which we have averaged, taking all those considerations of using one IOL model, one biometry machine, one type of surgery, one type of data, and one type of refractive way of doing refractions. And we calculate that A constant and use this for our own IOL power calculation for that particular type of surgeries. So usually 24 or 5 or more cases are needed for meaningful results. And so what we are doing is basically back calculating everything yourself for your case, okay? And obviously so as to get the best results and reach at the top, at the target. But remember, these calculations for the complex formulas, that was a simple example I gave for you for SR formula, which is the simplest. But that formula is anyway obsolete, as I told you, SRK. For surgeon's factor, which I told you is a part of for your Holidays formulas, obviously look at this calculations. Oh God, I'm going to scratch my mind. Will I be able to do it? This involves a lot of mathematics into it. So it's not possible to do this manually. We have another method by Aristodemus, who also is trying to predict this error. And here he is not going to give you the actual A constant, but he's going to give you the prediction error based on your measured values of your refraction and the predicted post-operative refractions. And here he's asking you to do take an average of almost 100 eyes. And if the prediction error is going towards hyperopia, he's asking you to increase your IOL constant. And if it's going towards myopia, he's asking you to decrease your A constant values. And for every 0.1 diopter, I'm just giving you an example here. For 0.1 diopter of hyperopic error, if you use the Hopper Qs, he says please increase it by 0.06. For Holidays, increase it by 0.06 again. And for SRKT, increase it by 0.12. But this is another method, which requires almost again 100 eyes and again requires you to do a lot of manual calculations. So the limitations of this manual paper and pen optimization is, as I showed you, very complex situations, very complex equations, high possibilities of your manual unnoticed errors which may come into there, and a time-consuming task. So what do we have available next? We have more sensible optimization strategies, which is using the biometry machine itself or using a separate software. So now what do we do? A biometry machine will give you this option. You can save your initial data in your biometry machines, enter the additional parameters which you require for optimization, that is your surgeon name, the IOL power, the model used, enter the post-operative refraction, and the machine will calculate this for you and update the relevant A constants. Again, you will require those many cases for this to be done. But is there an even simpler solution to this? Yes, there is. You can use an independent software, independent of the biometers. It is because you can work much easier and much faster on your PCs, which you carry everywhere with you, okay? And you can easily back up your data, transport and export your data anywhere from this. It is much, much faster, and there is no memory overload issues which will be there with their biometers. So be smart, use the software, and we have two optimizers available, Dr. Hill's spreadsheet and lens constant optimizer, which is given by one of my co-instructors who is not there with us now because he's totally gone into the fields of AI and he's developing more formulas and more work on it. So Dr. Saurabh has given this lens constant optimizer, who was one of the co-instructors who started this course actually initially when it was started in 2015. So this is the spreadsheet, how the spreadsheet of LCO version 5.1 looks like. Now, this is what is the conventional optimization I've talked about till now. We have taken the suggested A constant by the manufacturer, and which was 118.8 for the ultrasound, and it gave us, by this back calculations, the results of 119.1 to me. Now, can I go beyond this convention and personalize everything for my needs? Okay, we have two more tools for this, the dynamic IOL optimizer, which is again, and now these two are paid tools which are not freely available to you as softwares. So this is, one is DIO, which is again developed by Saurabh, and the other is by Dr. Holiday, which is a Holiday IOL Consultants, which actually personalize everything according to your as a surgeon. And what it does, I'm just giving you an example of DIO, because it maintains your database. It performs extensive data analysis, producing the optimized IOL power for each patient. Now you need not calculate your A constant for every patient. It will directly, after putting in all parameters, after using the best A constant for each type of eye, it will have a data source for myopic eyes, it will have a data source for hyperopic eyes, it will have a data source for the normal emetropic eyes, it will have a data source for other types of erratic eyes with those with corneal scarrings and everything. So it will optimize your results according to the data source which it has. So it is a sort of an artificial intelligence based tool again. A single usable IOL formula power will be provided to you at the end of the results once you're fed in the data. So everything is automated. So now, just to summarize, I would just say optimization, everybody would think, is it worth so much of effort? Yes, I would say it's worth the effort. But just optimizing your A constants, as Warren Hill said, you can come to 0.5 diopters, within 0.5 diopters in 70% of your cases, and within 1 diopters in 90% of cases. But if you use this personalization of the constants or personalization of the IOL powers calculations with the DIO, using even an ultrasonic biometer, you are almost as close to 96% for plus minus 1 diopters. And with the optical, you are almost within 99% of your results. So please, yes, it's worth the effort. Please optimize for every patient. Thank you.
Thank you very much, Dr. Vinita. May I request in the limitation of time, Dr. Vanatri to present the next talk. Are there any questions? We can take them at the end. If any questions.
Vanatri is coming. I'm ready for questions. Any questions we can take up till she starts with her. Just 1 minute till she starts with the presentation.
Dr. Vanatri is going to talk about refining the torics, and most of us, like me, are not even aware of the meaning of the word toric. So this will be an eye-opener to all of you. He doesn't know the meaning of the word toric, huh? I mean, I'm talking about the etymology. Okay, I'm not talking about what it actually means. So, ladies and gentlemen, while Dr. Vanatri comes on, remember we're talking about cataract surgeries, which is the most common surgery performed in the world. Remember, not ophthalmic surgery. Cataract surgery is the single most common overall surgery performed in the world. So we're talking about that, and we're going to talk about intraocular lenses, which is one of the most important things, because even now, I tell you, the next day when I open the bandage, or rather no bandage these days, my heart is always quaking. Is this fellow going to read, or is it come a 0.75? With all the things we have, even then I'm still worried the next day. So we go to Dr. Vanatri.
So I do have 7 minutes. 7 minutes. Okay. Yeah. Okay. So I'm just sort of going to rush you through because of the lack of time. Have no financial interest in the mention of any of the products during the course of my talk here. What we want to know is, why are we emphasizing so much on astigmatism correction and cataract surgery? Are we sort of doing an overkill on that? The fact here is because the preoperative astigmatism in corneal patients can range as much as 33% of them having more than 1 diopter of astigmatism here. And as we all know that when the cyclotorsion, which goes beyond about 28 degrees, can be seen in up to 68% of their cases here. So if you do not correct your astigmatism, which is commonly measured on a sitting posture, and the patient is down on a lying down posture here, and these cyclotorsion variations, if are on a higher quantum, can result in poor prediction or can result in less than optimal refractive correction in the postoperative phase here. So that's why we are emphasizing so much on correcting astigmatism in our patients here. The next is we should know which are the patients in which we can probably give torics, or in those we probably do not want to give torics or consider torics here. So wherever you're looking at a cornea with a higher quantum of irregular astigmatism, those are the corneas in which you would probably are going to be skeptical about giving toric IOLs or placing toric IOLs here. So under these you would have patients who have a corneal ectasia, who have scars here, those who have zonular instability, those who have posterior capsular dehiscence, and relatively those who have poor pupillary dilatation, because you might have difficulties in your surgery or difficulty in placing your lenses in the bag here, and patients with prior VR or glaucoma surgeries, then those are patients where you have a compromised posterior segment and you're going to be skeptical on placing the lenses in these patients here. Another is knowing your devices, what are the various devices which are currently available to measure the quantum of astigmatism in your patients here. What can refine the way you look at, or way you are, or way you want to refine your toric correction in your cataract surgery here? What's advanced here, you do have the image guided systems here. I personally have experience with the Vivian and the Callisto systems, no financial interest here, and those are what I'm largely going to show you about. So these image guided systems help to do away with the preoperative manual marking, because there might be errors in the way you're marking these patients here, and they have an iris fingerprinting embedded in the way the artificial intelligence works here, and this helps you to refine the patient's toric when your patient is on a lying down position as well here. Next is knowing what is the various types of IOLs which are available in the market here, which do offer a toricity correction for you, whatever be the make which you're choosing, or what you're comfortable with, and what you feel gives you better predictability in your hand. So again, these are all available in literature, and you can pull out and read these articles. I've given the references out here to enhance your knowledge. Due to lack of time, I'm not going to go into the details. The same when you look at multifocal IOLs, but largely now the current trend or practice pattern is that you've moved on from using multifocals to using a higher quantum of trifocal IOLs, or adapting a larger amount of trifocal torics in your practice here. So that's what you need to look at. Again, what you need to know when you're doing monofocal torics and you're doing trifocal torics is the quantum of astigmatism you want in. Normally, if you have the virgin corneal astigmatism of more than 1.2 is what's going to be your borderline when you're considering toric IOL implantation. But when you're moving to presbyopic toric IOLs, the quantum which you're going to use is much lesser. So if you're looking at the astigmatism more than 0.7, 0.8 on the ocular surface here, the corneal toricity, then you're probably going to look at a toric in terms of trifocal IOL. So that's how shifting from monofocal torics to trifocal torics is going to work when you're planning toric IOLs here. Again, what are the important steps you need to place importance on is your preoperative planning, the way you adopt marking, the intraoperative alignment here, and the postoperative management of cases which have surprises here. So this is largely how you would go about, and this is what you need to place and what you need to look at when you're approaching or when you want to refine your toric practice here. So the magnitude and axis of astigmatism, looking at the realistic expectations of your patients, the kind of IOL you're going to implant, ocular comorbidities of the patient, and last but not the least, do your preoperative IOL calculation preoperatively and not on the day of surgery here. So that's a large step in refining, even if it is going to be a non-toric IOL in your practice here. There are several types of marking systems. I think you would have heard several courses here which talk about the type of manual marking systems, which the several marking systems systems which you do have on your smartphones, which can help you, and they are more cost effective. And you have the more expensive, the digital marking systems, the Varion, Callisto. But what's on top of the line is the interoperative aberrometry here, and that really helps you to refine and cut down your quantum of astigmatism. But you do need to have a larger inventory of your lenses or lenses when you're using an interoperative aberrometry for your things. Your location and size of your surgical incisions need to be precise, and these need to be fed into your preoperative whatever toric calculator you're using in. Your surgical induced astigmatism has to be calibrated here. Capsulorhexis needs to be accurate in your patients. IOL positioning dot on the axis you have marked here. And when you do use the femtosecond laser assisted surgery, you can probably use add-on and give limbal relaxing incisions and change your IOLs to monofocal IOLs here. But when I do trifocal torics, I would not prefer to place limbal relaxing incisions in these patients here. Again, we'll skip in, and there's a lot of literature looking at comparison of the various marking systems here. But the slit lamp marking system also works fantastically well as in comparison to many other, as in comparison to the other pendular or other types of markers here. This is what we do after we implant here. Before we implant in an intraoperative aberrometry, you can do an image capture here, and that gives you the sphericity and the toricity and the axis of the IOL which you need to implant for your patients here. And after you implant it, again, it will guide you onto the axis in which you need to place your IOL, and this will effectively tell you if you placed in the right axis, and will also guide you to where you need to rotate your IOLs into position here. I think we have many more speakers coming on, so I'll just run you through one particular video to just show you this, or I think we can skip this as well, because this is a routine cataract. This is a flax patient here. You could see a nicely done capsulorhexis in this patient, and the phacoemulsification is completed here. And after completion, we are placing the toric IOL under a Varion guided image guided system here, so you do not see any further markings on, and these guided systems will help you to place your IOL in the absolutely required axis here. I think we'll stop here and we'll take more questions on. Or do you want me to continue? I have lots more. I do have lots more and case examples, but I think we'll stop here and take discussions to look at the practical aspects of how we would go about managing toricity. Thank you for your patient hearing.
You can take examples if you have anything.
We'll do it at the end if we have time, because we are
sorry for changing the order of the talk, since Rishi has to go for another talk in another session. So he was actually supposed to see how to deal with a patient who lands with a refractive surprise. So when he had an unhappy patient, how to manage him. So this is what he's going to talk about. So he's going to tell you some things in the beginning, and in the end probably we can discuss again.
Thank you, Dr. Vinita, for including me in this IC yet again. It's been running for many years now, and it's really a good course. Sorry, I'm jumping the queue. This should actually come in the end. So if all the things that you do with them fail and you end up with a refractive surprise, what should you do? So obviously it's better to prevent than try to fix this, and we should identify which are the high-risk patients. I'm sure a lot of this will be covered by the subsequent speakers, so I won't delve into that. You need to understand why it has happened. So it's important to do some basic tests, go back and check your IOL calculation, see if there have been some entry errors, or if you use the wrong mode or something else has gone wrong. Usually, whether the lens is in place, whether it's tilted, is there phimosis which has moved the effective lens position, whether there's a capsular distension syndrome, is there viscoelastic behind the lens, etc., and some difficult cases where you do expect surprises like scars, post-refractive, ectatic corneas, etc. Now, once you are in this situation where you have a refractive surprise, what are you going to do? You can fix this refractive error by one of these ways. You could change the lens if it's not too late. You could add another lens on top of your existing lens, which is the piggyback lens. You could do some sort of a cornea-based correction, which could be either surface or a LASIK or even SMILE. And then you might want to treat the cause. If there's specifically like a capsular distension syndrome or the lens is not in place, you will try to fix that. So if it's in the immediate post-operative period, recheck everything, including the IOL calculation in pseudophakic mode, check the preoperative data, IOL calculations, make sure the right patient received the right lens and you didn't make some sort of an error of giving the wrong lens. And of course, capsular block syndrome is a very common thing and you'll get a myopic shift. So you must look for that and keep that as a high in your index of suspicion. If it's a multifocal lens, patient has come 2 to 4 weeks after surgery, it may be good to just exchange the lens, but piggyback is also not a bad option. If the patient has come very late, then better to go for a piggyback or a surface treatment on the cornea. If it's a monofocal lens, up to 4 weeks, we could do any of these options. But after 4 weeks, again, you don't want to really change the lens, piggyback, a surface ablation or a LASIK. If you're doing a LASIK, make sure if you're doing a femto flap, the hinge is at the wound site. Otherwise, you'll end up with a problem in the flap. If it's a toric IOL, if the IOL is rotated, then you need to go and put it back in the original axis. If you have the original calculation, just look at that and fix it. If you don't have it, you can use this thing called astigmatismfix.com, or you could use an Biometry like iTrace to help you plan the rotation. Examer laser treatment or an IOL exchange or a piggyback IOL could also be done in extreme cases. So this is this website astigmatismfix.com. You just have to enter the data and basically click calculate, and it will tell you in a diagrammatic fashion how much you need to rotate the lens in which direction, clockwise, anti-clockwise, and it will tell you the estimated residual astigmatism. So that's what you want to do. Okay, so IOL exchange is another option. This is a video I borrowed from Dr. Harshul Tak, my friend. So I think it's a good idea to put in the second lens first and then cut and remove the other lens, so it makes the IOL removal a little safer and you don't end up damaging the bag. That's what he's demonstrating here. And of course, then you put the lens at the appropriate axis. So I'll just show 2 cases and I'll close. One is this one case. Uneventful cataract surgery, everything was perfect. You can see it's a good rexis, well-centered lens, but immediately post-op refractive surprise was -2. So what could be the cause? It's right there. You can see there's a gap between the posterior surface of the lens and the PC. So this is a capsular distension syndrome. You can see there's trapped viscoelastic, which has caused a myopic shift. So one of the ways to manage, which has been described, is that you yag the peripheral anterior capsule, or you could go and wash the bag. So that's what we did in this case. You can see that little star-shaped yag there. So you have to choose an area where the haptic is not there, peripheral to the optic, and you can yag it, and hopefully that will release in a viscoelastic. This doesn't always work. So in this particular case, it did work. You can see then in retroillumination and in high mag, the side of the opening. So here it resolved, and the patient got back to emmetropic result. Otherwise, one could go and wash the IOL, or one could even do a posterior capsulotomy, but it's not ideal in the initial postoperative period. Of course, prevention is better than cure. Do a good wash. This was another patient, 61-year-old, underwent multifocal lens 6 months ago. Refractive surprise was like this, quite bad. Very unhappy patient. Cylinder as well as spherical error. It was like a mixed astigmatism. And so she was planned for a piggyback toric sulcofix lens. There was obviously there was an element of phimosis also, which might have shifted the effective lens position, but I didn't want to do 2 interventions, so I just directly decided to do a piggyback and just enlarge the capsule opening. So we used this lens from the care group called sulcofix, add-on sulcofix, and I decided to go with a toric lens. So as you can see, we've enlarged the anterior capsule opening and then basically implanted sulcofix lens in the sulcus like so. It has 4 haptics, so it sits quite nicely in the sulcus. There's another lens from Rayner called the Sulcoflex, which also works very well. You could use either of them. This works quite good. So this is the patient after surgery. You can see the 2 lenses there on the slit picture, and the patient did quite well. So who are the ideal candidates for a piggyback lens? Primary IOL is an intact capsular bag, normal or deep anterior chamber, not a shallow chamber, no glaucoma, no pigment dispersion, no endothelial problems. Choice of surgery for hyperopic errors particularly, and choice of surgery for patients who present late and have a significant higher order aberration which may not be laser correctable. So this is how you use the formula for piggyback calculation. I'm sure somebody will cover this in the subsequent talks. So the other lens, like I said, is Sulcoflex from Rayner, and that also works very well. I'll skip the video for that. So to conclude, refractive surprises are best prevented by good biometry practices and surgical safety practices. But if they do occur, they can easily be treated either on the cornea or a lens-based approach with good outcomes. Thank you.
Thank you, Rishi. Next talk is basically dealing with the extraordinary. And obviously, this will cover the situations which I had listed in my initial slides of the first talk. And so she'll be dealing with the abnormal situations of suboptimal eyes, which can be high myopes, high hyperopes, those with scars, corneal scars, and those with probably silicone oil in situ as well, when you have to do a cataract surgery after some months and you have silicone oil after a VR surgery. So you have all sub situations in those cases, how to deal with, how to get the best results is what Jaslyn will be talking about.
Thank you so much, and sorry we have overshooted the time a bit. We got the session a little late, so bear with us, and we'll try and make it really short. So we are talking about refractive cataract surgery nowadays, and our patients are very interested in a spectacle-free life. So an optimal biometry is giving us very good results when the situation is in the normal range. But what about when we have out of the ordinary situations? So if you have eyes that are very large or very short, or patients who have, like we've covered, astigmatism, so we have to deal with these eyes very differently. First of all, we must counsel the patient that no matter what, however the accurate measurements and repeatable measurements we take, you may still land up with a slightly off-mark IOL power. And this is very important so that the expectations are kept within that limit. So why does this happen? So when you have an eye which is either very long or short, so the effective lens position cannot be predicted that accurately. And secondly, the measurements may not be also very accurate. The IOL availability and labeling issues are also there. So you do note that when the IOL power is very high or very low, you do not get them at 0.5 diopter range, but rather at 1 diopter. So you need to then see which particular power would suit them most. So the newer IOL formulae have really helped in these eyes, particularly because in addition to the axial length and the average K, there are a lot of other parameters that are being taken into consideration. And the most important out of them is the white-to-white horizontal measurement. And this plus the fact that it was understood that the previous formulae were sort of based on larger lens having a deeper AC and shorter eyes having a shorter AC depth was not exactly true in most of the cases. So other thing that is very important when you are dealing with these eyes is that you must personalize your A constant. So use the newer generation formulae, use better biometers like the IOL Master and the Lens Star, and input all the measurements, particularly if you've done the other eye, then take that also into consideration. And when you're measuring, for example, in the myopic eyes, you have to see that optical biometer is the way to go forward. You should be able to see the fovea. And if you do a contact, you must avoid a contact. You could, if you do not have the optical biometer, do an immersion scan, and in that case you should try and see that you have the A and B scan together, so that you are able to see that you are at the fovea and you're not at, say, a posterior staphyloma. Always aim to be a little myopic. And in the formulae, of course, the Barrett Universal 2 is something that is doing very well in most of the extreme eyes. And you could use the Wang and Koch adjustment in the holiday when the axial length is 24.5 to 26 millimeters. And the Hill RBF method uses artificial intelligence and is recommended for IOL powers of +6 and above. So in the extremely short eyes, here again, the optical biometer again. And something to remember is that the short eyes are very unforgiving. So a very small error is going to be magnified in very off the mark IOL power. So, for instance, if a change of axial length from 20 to 19 millimeter would change the IOL power by 5 diopters. So, really repeat your measurements, use the optical biometer, and the fourth generation formulae like the Barrett Universal 2, and Hoffer Q is more accurate if you're using the ultrasound biometer. So again, I talked about the IOL labeling. So in case there is a slight error also, that is going to be more magnified in these extreme eyes. And piggyback was already covered, so I'll just skip that. So yes, I think most of us are using multiple formulae and getting reiterated what is it that we must put in these eyes. And if you have to place the IOL in the sulcus, then the effective lens position has moved forward. So here you need to adjust the calculated power, and the ranges are given in these in this table. It's very easily available. And in the silicon oil filled eyes, you need to see that the speed is going to be affected, so you have to sort of give it, there's an error if you do not modify the power. So usually the power required is 2 to 3 diopters stronger than the standard power. And I think I will just close it here. So use particularly multiple readings, multiple formulae, optical biometers, and also check what the other eye is if it is pseudophakic. Thank you so much.
So, without much of discussion, we'll go to the next talk, which is by Dr. Shashwat on the post-refractive cases. So, we'll be talking about how to deal with the eyes and how to do eye calculation for the eyes which have had a refractive surgery.
Good afternoon, gentlemen. I'll be sorry to impinge on the next talk, but I'll just make it short and sweet. Hopefully, it'll be short and sweet. So here we are talking about something post-refractive surgery eye power calculation, which can be alternatively called as biometry from hell. This is so difficult sometimes that I know certain surgeons in Delhi who refuse to operate on post-refractive surgeries in the sense that they will not get a proper IOL placement. So it doesn't need to be as bad as that. So let's talk about the three problems that we have. Why is this such a big problem? The first problem is instrument error. We'll discuss this in a second. Keratometric index error and the formula error. Okay? It's important to understand that instrument error is because you see we use keratometers which measure the paracentral cornea, not the central cornea. So 2.5 to 3.2 according to the instrument. So what we measure is the paracentral area, and after refractive surgery it misses out the central area which is flat, isn't it? So we're measuring basically the paracentral and we are missing the flatter zone in the center. This adds up to 15% of overestimation because of the steep paramedian. So that's quite a lot. Okay, that's one. And second is the number 2, index error. Index error has been talked about. See, the refractive index of the cornea is 1.376, but keratometry assumes it's 1.3375. Why is that? Because it makes life simpler, because it converts a 7.5 millimeter radius into a 45 diopter. You know that we cannot calculate the IOL power, the corneal power directly. We have to calculate from the radius. So if I take a 7.5 millimeter radius, it gives me a 45, so which is this assumption. But this assumption is based on the fact that the back to front ratio is 88%. You know that the posterior corneal curvature is more curved, is it not? So we take that ratio, radius curve is 6.8 divided by 7.7. This is the 88% is the normal ratio in a virginal cornea, but this changes when we do refractive surgery. The 88% after myopic becomes 68%, and after hyperopic glasses becomes 90%. So we cannot hold this assumption. With the result, we'll end up with index error. So these two errors, how do we solve that? We solved it. Look at that, 15% and 10%, 25% error in keratometry. So the only way to solve this is to do it directly. Okay, so we do direct measurements, anterior and posterior corneal curve, which is how to do that. We do these topographers and like Pentacam, Obscan 2 or OCT, whatever is available. The nowadays standard of care is Pentacam with its Schindler camera In 2 seconds, it captures 25,000 points. And because it has a single fixed meridian, so in the 2 seconds that it needs to capture, if there is a movement of the eye, that error can be minimized. So this is nowadays the instrument of choice for most of us, where we use a pentacam. And so let's look at that. So what we do, amongst the many maps, we pick up the holiday report. Remember, the pentacam comes inbuilt. There's a default setting of holiday, and my advice is not to change it, not to tamper with it. And we pick up this map, which is called the EKR, equivalent K reading. What it does, it measures the central corneal powers across various diameters from 1 to 7 millimeters of the cornea. Okay, so you can see from 1 millimeter to 7 millimeters, you have a choice, but the EKR 4.5 is the best for central corneal power. Reason being that if it's less than 4 millimeter, you exclude too much of the pupil. And if it's more than 5, then the Stiles-Crawford effects with the directional sensitivity may cause an error. So best is to take the EKR 4.5 zone. You get your keratometry. The third error we have not yet taken into account, and that is the ELP. Remember, ELP, as mentioned by the previous speakers, is the most difficult. It's the holy grail. The effective position of the postoperative IOL is the most difficult to measure. And the third generation formulas, usually, which is called the American formula, all the Hoffer-Q, holidays, SRKT, they predict the ELP via a combination of axial length and keratometer. And this makes a false assumption, because now it's a flatter K. A flatter K would assume a shallow RACI and estimates ELP more anteriorly, but this is not true, as just Dr. Jesslyn told us. So this is not true, because actually there's no change in the position of the ELP. It remains the same. So this is another error introduced, and to neutralize this error, we have a double K method of Aramberry, where we use 2 different Ks. Okay, the first K is for measuring the ELP, and the second K is for IOL power calculation. And if all the formulas that the Americans, as I said, they have to include this correction, otherwise we cannot go ahead with the calculation power. And let me give you an example. If you don't know what happens, see, if you use a preoperative K of 45 and a post-refractive keratometry of 36, a normal standard refractive surgery, IOL 24.5, and now you want to implant an IOL of 18.9. With the holiday one, aiming for emmetropia, we get a 26.6, no double K. However, with the double K correction, we get 29.37, which leads to about 3 diopters hypermetropia, which is less than 6 by 60 next day, okay? Because there's no accommodation anyway. So that leads to a very unhappy patient. So what happens? So therefore, what do we do? So we have, let me tell you one important trivial question. Number of formulae published for IOL power for refractive surgery, we have almost 36. And at the time of speaking, there's some more going into press. So how do I take formula? The simplest thing I have to advise you is to go to the online calculators, freely available on SCARS. You can have iLabs and have APACRS. The most popular is usually the ASCRS. It's completely free. All you do is to go to the website, fill up the details like this. It's very clear, there's no doubt about it, and press calculate. Very simple, we press calculate. It takes an average of 7 to 8 different formulas and presents us with an IOL which you can choose. Let me give an example. A pre-LASIK refraction of -11, a post-LASIK of -2.2. Many of us, we deal with this kind of fractions. Pre-LASIK keratometry is 42, but post is 36. And axial length of 28, AC depth of 3.5. And see how we apply this. And this is the IOL power, the online calculators, you don't have to do this. Correct corneal power is not the refractive correction, but at the corneal level is not 11.25, it's 9.91, applying various formulas. Post LASIK is 2.9, not 2.25, but 2.91. So we have a difference of 7.72 at the corneal level. So that's completely different. And the corrected K is 42 minus 7.72, which is 34.2, which is not the same as 36, which was assumed before. And with this, we get an IOL power all calculated by multiple formulas by the online calculators of 20.6, one group of formulas by Sharma's, 20.4, 20.8 by Haggis, 20.6. We take an average of 20.6 to final 21, and we'll end up with an amazing refraction of only post-op -0.5 cylinder at night. Astonishing, but true. So this is the latest standard of care. RK is another problem. Problem is that you see both surfaces flatten. In eczema, only the anterior surface flattens, not the posterior. But both surfaces flatten RK, but not equally. The posterior surface flattens more, about 33%, anterior surface only 22%. And that causes another element because the optical zone is smaller here, 3 millimeters. So instrument error is more likely. Okay? Again, we do the same thing, estimate the corneal power, fill up the formulae, and if you don't do that, look at what a case report published recently. 43-year-old male with a left eye cataract, RK done 17 years back for -11 and 8 cuts RK. Pre-op refraction with the -2.5 with the -4. This is before with the cataract. And K150 to 1, K2 38.5, Axon 30.5. Remember, he's -11. IL power with SRKT was 1.5. The surgeon wanted to be on the conservative side, so he implanted 3 times. He implanted 5 diopters, and yet the refraction comes out to be +12 with the minus. That's incredible, and you know what is going to happen next. So, my friends, again, I must insist that we go back to the IL calculator, fill up the details, and what are the take-home points therefore? Patient has to be told about unrealistic about his expectations. We estimate the IL power, we do not calculate it in this case, in this post-refractive. IL has to be checked with multiple formulae. No single formula is the best, except the Barrett's 2K is coming out a little better. And when in doubt, always choose the higher IL power and avoid multifocals like the plague. Thank you very much. And any questions are welcome.
No questions allowed. We just have to finish the last talk of the day. Sorry. We got the session 15 minutes. Just 5 minutes. Shalini will finish a talk. Sorry. So we also got the session 15 minutes late. So just 5 minutes for our last talk, which is on pediatric biometry. This is an important topic.
So good afternoon, everyone. I'll try to finish it fast. So the relevance of the topic is because there are technical difficulties in measuring biometric parameters in children. Now, use of IL power calculation formula, which are designed for adults, cannot be used for children. But then we don't have any option. Moreover, the growth of the eye is influenced by visual experience and visual deprivation, which leads to elongation of eye and myopic shift. Now, what are the factors that affect the choice of IOL in children? Primarily, it is biometry, that is K and axial length, IL power, myopic shift, target refraction, amblyopia, and age at surgery. So, when we talk about optical biometer, is the biometry, optical biometer is the gold standard. But how many children can we make sit on the biometer? We need to do it under general anesthesia. Now, when we talk of keratometry, autokeratometers, handheld keratometers are required. But actually, how many centers are having these handheld keratometers? So, what we need to do? We actually, to take out these problems of keratometry, we need to actually put the adult values, or we can put these mean keratometric readings which are present already present in the literature. At birth, it is around 52.2 diopters. At 6 months of age, it is 45.2 diopters, and at 18 months, it is 44 diopters. So we can put these readings to get a better IL powers. Now, regarding the biometer, we can do immersion under general anesthesia. Now, 82% of people are still using contact biometry. So, what is the option? So, we have to move on to immersion technique under GA. We understand that errors in axial length measurement can lead to an error of around 2.5 diopters in adults. Now, in children, because they are shorter eyes, this error is even more. It is 3.75 diopters. So we need to use immersion, not contact biometry in these children if IL master is not possible. Now, coming to another important factor which we face is cycloplegia. Now, it has been seen that cycloplegia resulted in decreased axial length measurement in children. So, and moreover, most of the time we are doing it under cycloplegic axial length measurement in children. So, we have to avoid that. Now, next question arises, which formula to choose? Because a formula, these are for adult eyes, and in children, they are developing eyes. They have got shorter axial length and they have large corneal curvature. So, in those cases, it has been demonstrated that the formula, they show high degree of variability. Now, this infant phakic treatment study is an important study which have found that SRKT and holiday 1, they have the least variable results in children. So that formula we can use, but Hoffer Q we have to avoid because it is most variable formula in children. So now coming to another important factor, which is myopic shift, because children, they start with hypermetropia, they gradual increase in the axial length, and later on there is a myopic shift. So what we target is in adult we have emetropia or mild myopia, but adult metropia, if we target in children, we have to reduce the IOL power of the child. But if we do under correction, so that we in adult we have amblyopia due to the hypermetropic shift. Therefore, we have to determine the post-operative refraction, and ideal eye power should be a balance between the two. So the Dahan's formula is good for in such scenario. We need to do under correction. For children under 2 years of age, we can do under correction by 20%, and for children between 2 to 8 years of age, we can do under correction by 10%. But most controversial is age of less than 2 years of age, because if we do under correction exactly 20% up till 22 years of age, then there is a problem. So what we can do, we can slightly modify, like at birth we can do 20% of under correction, at 6 months we can reduce it to 17.5, at 1 years of age we can reduce it to 15%, and at 2 years we can make it 10%. So that way we get less of residual hypermetropia. Now similarly for more than 2 years of age. Now another important thing is post-operative refraction. Age of the child is important, because suppose the child is of 1 year of age, we need to have refractive goal of around 6 diopters. If the child is 8 years of age, we need to have a refractive goal of around emetropia. So moreover, we need to check the status of other eye also. Suppose other eye is emetropic, unilateral congenital cataract is there, and we make him hypermetropic by plus 6 diopters. Obviously, he is going to get amblyopia in later period. So we have to assess the status of other eye also. So what are the warning things? We should be prepared for refractive surprises in children. So we can also do on-table retinoscopy, and then we can implant the IOL there and then. But sometimes inventory might not be accessible for that particular diopter. So what we can do, we can do retinoscopy, and after a week we can do a secondary IOL, or later on if you required, the IOL exchange might also be required. So the summary is that there is no ideal method. We need to titrate them for children, and it is always better to do it under general anesthesia, do retinoscopy and find the IOL power, and then implant the IOL. Thank you so much for your kind attention.
Extremely sorry for the next session.